On behalf of the American Academy of Neurology and in collaboration with Neurology Today, it gives me great pleasure to introduce Dr. Sanjay Gupta, CNN Chief Medical Correspondent and Associate Chief of Neurosurgery at Grady Memorial Hospital in Atlanta. Sanjay, it's just really a pleasure. It's a privilege to have you with us today. On behalf of all of us in healthcare, the public, who are, all of us that are fighting COVID-19 out there, and our 36,000 members globally, thanks for your tireless efforts in reporting and for joining us. The American Academy of Neurology.
Thank you.
Yeah, of course. The American Academy of Neurology, we can get along, neurologists, neurosurgeons, perfect. Even in a pandemic, we can get along. You've been on the front lines of so many different disasters, from the catastrophe, the earthquake in Haiti. I think you actually jumped into action. You had to operate once when you were there. You've seen SARS. You've reported on so much in the last several decades. This is forcing neurologists to just, think about things differently, practice out of their comfort zone. How does this compare? How does this pandemic with COVID-19 compare to other catastrophes? And maybe what advice do you have from a Gestalt perspective about, how this is going to affect neurologists?
Yeah, it's interesting. I think with a lot of other situations like Haiti or natural disasters, even conflicts, there is a sort of built-in timeline a little bit, even if it's not totally, firm. You sort of have some idea of how long something's going to last or how long you're going to be involved with it. With this, pandemic, we really have no idea, and truly, you're sort of living it at the same time that you're reporting on it, as are you and probably a lot of people who are watching right now. You're taking care of patients and living through this at the same time. Mm-hmm. So I think it's really different in that regard. I have covered, I covered H1N1, which was the last pandemic, but it became pretty clear, fairly early on that it wasn't going to be nearly as lethal as even seasonal flu at that point. Mm-hmm. So this one, as soon as we started seeing some of those reports out of China, early, sort of second week of December timeframe, there was already a lot of concern among certainly public health community, but also the medical journalists who've covered these sorts of stories. Mm-hmm. I think that from a Gestalt standpoint, obviously there's so much that we're still learning about this. There was a paper just published in, I think, Gastroenterology this past week talking about a whole new sort of subset of symptoms, which ended up being a lot more common than people realize. That is to say that 50% of these patients are presenting actually with the GI symptom. That wasn't even in the initial 42,000 person paper. It was all fever, dry cough, and shortness of breath. Okay. And now we hear that loss of appetite is occurring in 84% of the 50% that are presenting with this, diarrhea, abdominal pain, and vomiting. So these are all sort of new things. But I don't, so I don't know, I guess, what the Gestalt is for neurologists right now. There's new data coming out all the time. I think one of the big points though, and maybe, you've sort of fundamentally understood this, but when you look at these death rates around the world and really kind of get granular on them, Hubei death rate was around 2.3%, the province of Hubei in East Central China. Outside of Hubei was, 0.8 to 1%. And Hubei is, a fairly sophisticated province, not, it's uneven through the province, but really good hospitals there. So you ask, why is that, right? And as you may immediately infer, it really had everything to do with the strain on the medical system. Mm-hmm. So where you're seeing significant strain on the medical system, that's really what's driving these fatality rates, I think, much higher. There's other things, elderly population in northern Italy, big smoking population, both in China and in Italy. But I think the strain on the medical system is the biggest thing that we're talking about, more so than testing, which I think has become a little bit of a false metric here. Yeah, so that's the Gestalt, I guess, in terms of just from a health, more from a practitioner standpoint.
Yeah, I'm located in Weill Cornell Medicine in New York Presbyterian in New York City, and we've quickly become the epicenter. I'm so proud of our hospital. I'm proud of our students, our residents, our neurology residents being redeployed literally as we speak. All of our faculty, neurology faculty, we're going to get reassigned, whether it's to the emergency room, doing whatever we need to do, whether it's to be inpatient consults. Some of us are going to join the internal medicine teams, and some of us, maybe if you did an internship in surgery for some, they're going to potentially do surgery. So we're jumping in. And I think, neurologists, we're seeing things. We had just this weekend, we admitted 2 patients with myasthenia gravis in their 30s, two young men with myasthenia gravis who are, COVID positive. And wow, what do we do? Do we use hydroxychloroquine? Wait, will that worsen their myasthenia? But we need to get them to live. So maybe we can manage the myasthenia another way. There's so many idiosyncratic things. I think you reported just the other day about anosmia, lack of smell as a presenting symptom. Maybe tell me a bit about that.
Sure. Yeah. And just on the previous point as well, Doc, with those patients, for example, with the myasthenia gravis, I imagine that was more acutely the problem. There is a significant percentage of the population that is 20 to 44 that is being hospitalized, but for the most part, the really severe illness is in the elderly. So just with the myasthenia gravis patients, did you end up treating them for their MG?
Well, we needed to stabilize them first, and that was the key. We have them on oxygen. We had a tricky decision about hydroxychloroquine, and the data is honestly not really that solid. But when you have a crashing person in their 30s that's hospitalized, it's these are tough questions, and we decided maybe we shouldn't use it because it could worsen the myasthenia. But these are questions that neurologists just haven't ever even thought about. We have patients with multiple sclerosis who are at higher risk. We have also patients maybe who are not presenting with neurologic complaints, but patients who are normal when they come in and they present with neurological complaints possibly due to coronavirus. So, we talked about the symptom anosmia that was recently reported. And there was a report, it's not been peer reviewed yet, but it came out about a month ago from China that about 1/3 of coronavirus patients had some type of neurological symptom, whether it's altered consciousness or skeletal muscle damage or acute cerebrovascular disease. And that was much more common in severe cases. And this is something we've never seen before.
Right. Yeah. No, I mean, it's forced a sincere humility, because every day, well, not every day, but very often there's new data that's sort of coming out about this. The anosmia thing, there was actually a sort of small case series that came out of China. I think it was in January, but it was pretty tiny, and it was hard to sort of disentangle it from the other symptoms the patients were having. But now it's become clear that patients can present with anosmia as a sole presenting symptom, aside from congestion, aside from runny nose, anything like that. And then those patients, they're getting the idea that if they're going to progress to hospitalization, most don't, 84 or so percent of the patients in that study did not progress to hospitalization, but the ones who did usually progress around 9 days. So that gives you a little bit of an idea of the course of this. So, and one thing just about the hydroxychloroquine / azithromycin treatment, which I think you were referencing. It's really interesting, and this was something that I think was important. Again, this sort of inflection point between medicine and the communication of these topics. So that was a 26-person study, non-randomized, non-blinded, in France, and when they reported the data, there was 20 patients that were reported in the data. 6 patients were excluded. And I just bring this up because I think it's important and one of those real challenges, I think, as a medical reporter. But those 6 patients, we were really curious, what happened to the 6 patients? They weren't part of the final treatment group. Well, it turns out that one left the hospital just on their own, did not want to participate. One could not tolerate the therapy, the side effects. So sort of withdrew for that reason. 3 went to the intensive care unit and 1 died. So, very, very small study, but if you were to do the math on that and make anything of it at all, those mortality and morbidity rates are higher than the general infected population. Yep. So, I don't, it's like we were talking about, I think it's great to be hopeful, but, we wanted to make sure that people understood that a non-randomized, non-blinded trial, the reason it's limited is for this. Here's what you didn't see as part of all that. And they were already selecting patients they thought were going to, going to actually respond. So
Yeah, and I admire your skill and your thoughtfulness in addressing a topic like this, because when medical world and the political world and other interests are intermixed, I stay
yeah,
apolitical, but want us to
yeah,
be really careful about medical communication. And
yeah,
who's one person can say one message, and things can get really misinterpreted. I just read about yesterday about someone took some chloroquine, which is from an aquatic, from his I think
yeah,
it's for fish tanks or something, and the guy passed away, and then his wife is in the ICU. So that's not the right chloroquine. It's not the right drug. So these
not
are really dangerous things to talk about.
yeah. I mean, I think it's probably the real sort of thing that doctors deal with all the time. You want to be hopeful.
Yep.
Uh, you balance it with honesty. Honesty is obviously in lead position, but I think there's a danger. I think, as you're saying, to false hope. It's
Yeah.
not just I'm disappointed. I mean, people like this man out of Arizona. He died, and his wife's in critical care unit in Arizona. So
Yeah.
it's pretty frightening. There's also now, as you may know, chloroquine is now on the official global drug shortage list
Yeah.
just in the last week. And there
Yeah.
are people who take it for different reasons, especially the hydroxychloroquine for autoimmune disease. So it's I mean, there's all these ripple effects from those types of things, and
Yeah.
we just want to examine the evidence upon which this is based.
Yeah. We're learning a lot. We learned a lot from China. Yeah, I have a 4-month-old at home, so I've been scouring the literature.
Yeah.
JAMA Neurology, Lancet has had a lot of great articles. Practical Preventative Medicine is a journal from China. It came out a few weeks ago about babies, basically infants
Hmm.
from 1 month to 11 months. It was the first case series. So I was obviously worried and wanted to read up. The evidence is exploding, and, we're learning, more and more from the Italy experience, from the Spain experience. We have a partner that we're broadcasting this with, Neurology Today, and it's
Hmm.
really a periodic, the news source for the American Academy of Neurology. And literally today and tomorrow and every day going forward, we're publishing stories about talking to doctors on the front line, Spanish neurologists. We talked to the CDC neurologist the other day, and also a story coming out now from the experience in France. So our members are being updated, but the news and the information is coming so fast and so furious. I guess just to close, man, you've been through a lot. You've seen a lot. You understand the data. How bad is this? I hate to say it, but for a month, on February 18th is when I sounded the alarm. I actually sent a text message to a friend of mine and said, "Oh boy, we're going to run out of hospital beds in a month. Get your stock market money ready." I'm terrible at money management, but the stock market's going to crash. It's going to be a mess. And people without a medical background kind of said, you're overhyping things. And then, just there's even a handful of doctors out there that may still not see it. We're this is a catastrophe. I'm the heroic efforts of our healthcare system. We're down to limited masks. I'm sharing one mask with my wife and I because, I haven't picked mine up yet. And that's kind of what we're doing. And we're doing that all over the country. But there are probably pockets of physicians out there and practicing neurologists who, may have cut back their practice and, not seeing sick patients and maybe doing more telemedicine, which is great. They've loosened the rules and that's great. But if there's a neurologist watching this and that just doesn't really believe or think that this is something, this too shall pass, and in a few weeks, we'll stop the social distancing and go on with our lives. How bad is this? Where do you think we're going to be in a few weeks, and where do you think this is going to end?
Well, I worry that in a few weeks, the numbers are going to be much higher. I think that part of that is just because, if you look at the picture that we're getting right now, in some ways, you have to assume that that's a picture of the status of things, up to 2 weeks ago. That the sort of the latency time between exposure to developing enough symptoms to go get tested, if you can get tested, 7 to 10 days, and then a couple days for the test. So you're really getting a picture from 10 to 14 days ago, and you have to assume that over this period of time, the last 10 to 14 days, the virus has continued to spread. I think that I think there is a best case and a medium case and a worst case sort of scenario. I mean, there is a very reasonable possibility, despite the fact that we can't say for sure, that this has a seasonal variation to it, and that come next month, really, because that's when SARS sort of peaked. we may see a similar sort of peaking here. And as the weather is warm and the humidity goes up, for all the reasons that you get seasonal variation, you might see some benefit there. And the social distancing measures, if they continue to be implemented, which I think they probably will, at least for a couple more weeks, can be quite beneficial. I mean, China and South Korea have sort of come through this now. I mean, there could be a second wave over there, but there was sort of an 8 to 10 week curve, sort of beginning to apex to sort of the tail end of that. And that, I think we could go that way. I think the real challenge is, Italy's really become such a severe scenario because of the strain on the medical system. And we got to make sure that we are being able to deal with that. And there's some innovative sort of things happening. Governor Cuomo and I spoke today, and he's talking about the fact, well, maybe this makes total sense to you. I hadn't really thought of it myself, to be honest, they're dealing with it first now where you are. There's 20,000 ventilators sitting in stockpile. They're going to make some more. They sent, I think, another 2,000. You may have them for a period of time, and then the ventilators move, to another location. We tend to think of, these things all being static in each state, but it may be a question of moving these commodities around. Yeah. The worst case scenario, though, just quickly, I'll say is that, you have something that's circulating that if it has even half the lethality rate as we're seeing in Italy, you're talking about 1 million people will die, and many people will be hospitalized. Again, young people do get hospitalized with this. It's not just a live or die sort of scenario for them. So
the initial data, suggests that, if you're over 65, if, three or more pre-existing conditions, okay, those are the susceptible folks. Now, granted, if you're younger than 50, I believe the statistic was only, less than 1% die.
For survival. Yeah.
But how many people get hospitalized? Staying in the hospital. And something that I think you may have reported it, but I haven't heard this much, the persistent lung injury after this infection. I mean, what if I'm not able to run like I used to? What if people actually can't take care of themselves? The burden on the caregivers and healthcare system. I mean, do you have any information about the lung damage? I mean, that was worrisome to me.
Yeah, it was worrisome. So they define recovered in China. They define recovered in different ways in different countries. Some define it as absolute negative tests, nasopharyngeal swabs, two tests in a row on alternate days. So over 3 days, 2 negative tests. Some define it as absence of symptoms. Some define it as one negative test or just no clinical symptoms, all these different things. So it's a little bit of a hodgepodge in terms of how you define recovered. But in the recovered patients in this China study, what they found was that there was about 30% of them that had some evidence of impaired lung function afterwards.
30%.
30%, so about a third. Now, some of it was pretty minor, pretty minor lung. It was not noticeable except on their own pulmonary function test, but it got up to 20 to 30% diminished lung function. So significant shortness of breath, walking a block where there wasn't that before. People were describing in this paper some of their limitations as a result of that. But, we didn't find that out until, these patients sort of went through the recovered and then were followed about 4 to 6 weeks out. So we are seeing some longer lasting issues with these patients.
Wow, that is striking, especially for patients with neurological disorders who are already compromised. That can take a really, really big toll. So Sanjay, I just again, on behalf of the entire American Academy of Neurology and Neurology Today, I just thank you so much. You're, helping to raise, I've been saying this over and over. As a doctor, we need to be shouting from the rooftops that this is a serious condition, and we got to shout really loud. But you're helping people and you're getting them to listen, and I really appreciate your time. Just to switch gears, maybe to a little bit of a happier topic. As neurologists, you're invading our turf. You have a book coming out about brain health and about keeping the brain healthy using evidence-based interventions. Tell me a little bit about that. I think it's coming out in June. I heard great things about it. Why don't you tell me a little bit about it?
Well, I mean, and I mean this in total sincerity. A lot of the reason that I was motivated to write the book was because of the sort of work that you do, and this belief that we do have more control over our brains than we realize, and our brain health and what our brains can do in terms of warding off disease. I'm interested in the brain. I fully granted that neurologists know a lot more about most of these topics, frankly, than I do. But I was really I was just very interested in the brain, and I approached this sort of as a person with an interest in the brain who had a little bit of a journalist sort of approach to it. I did want to ask some questions about why do we have these notions of thinking of the brain as sort of this black box organ. We don't think of the heart that way. The best that we get is, what's good for the heart is also good for the brain. But how come we don't think of the brain in some sort of special way? Yeah. So demystifying a little bit, I think, for a lay audience. I also, was really struck again by some of the work that you've been doing in the papers that I've read that you've written about, this sort of this preclinical time when it comes to things like Alzheimer's. When you have evidence of plaque in the brain, but patients are asymptomatic. What is to be made of that preclinical time? How do we define adequate treatment? Is it important to actually have the drugs that are targeting plaques if we know that plaques are there in this preclinical time, and yet patients can be relatively symptom free? So how to explain that part to people, I think, was another goal of the book. And I think hopefully in a way that inspires them to do things that are helpful for their brain health. It's the what and the why. I think that always makes a better impression. And then finally, everyone, I'm sure on this call, and everybody who thinks about dementia overall knows that we haven't made a lot of progress with Alzheimer's, specifically in terms of therapeutics, aside from, a lot of the work that you're doing in terms of helping people reverse disease based on lifestyle choices. In terms of therapeutics, we haven't. And this sort of correlated with the previous thing. Why not? I mean, has the questions that everyone on this call's heard, what has amyloid plaque gotten too much attention? What about tau? But what about, even more important, this preclinical time, So that was the goal. And I wanted to travel and also learn from some other cultures. I spent time in Guam, for example, where they have a really high incidence of Alzheimer's, ALS syndrome. Right. So are there lessons there? But that was it, and I really enjoyed it, because I learned a lot, and I'm applying some of these things to my own life, and now making my kids, I have 3 teenage girls, I'm making them do some of the things I learned in the book. So it was great. It was a useful experience.
That's great. I'm really excited. We can hit the pavement and put our heads down and do the research, but to really spread the research in a way that the public understands in English, and getting this message out there in a responsible, balanced way, that just like you said, you can grab the bull by the horns, and people can take control of their brain health and reduce risk. Yeah. We don't have a magic pill or a magic bullet, of course, but there are definitely things people can do. And most neurologists don't realize that there's 46 million Americans today that have, the pathology of Alzheimer's beginning in their brain, but no symptoms, just like you said, preclinical or pre-symptomatic Alzheimer's. So appreciate you getting the message out there, giving people a hopeful but balanced roadmap for that.
Well, thank you. And again, sincerely, thank you for your work, because I think it's very inspiring. Like I said, I've already adopted a lot of it, and I think a lot of other people will as well.
Sounds great. Well, Dr. Gupta, it's just been absolute pleasure. Much respect. Thanks so much. And get out there. You got some reporting to do. I have a feeling we'll be seeing you. And just for those people watching, all of this information has been current as of March 24th in the late afternoon. We'll post this as soon as possible. We plan on doing several of these briefings, honestly, as many as possible, on a variety of topics. We're going to talk about wellness. That's an important topic. You taking care of yourself? Are you?
Not as well as I'd like, I'll be honest. I'm just not getting enough sleep, working a 24-hour news cycle, and then, so much of the news coming out of China, which is the other end of the clock. So, we're just constantly, not practicing what I preach now, but hoping to make up for it.
Let's focus on that. That's bad for brain health. And
I know.
You haven't slept. Right. And fast forwards the bad stuff. But we'll keep everyone engaged. And if you have suggestions about what to cover, you can shoot me an email at rii9004@med.cornell.edu. Sanjay, absolute pleasure. Namaste. Thanks so much. Thanks. Bye-bye.
Call anytime. Thank you. Bye-bye.